Okay, there's 13 participants and I think we can start now. Okay, so welcome to everyone to this webinar organized by Rare Diseases International. This webinar will provide you with an introduction on the Global Commission to End the Diagnostic Odyssey for children with a rare disease. And it will also be an opportunity to collect your feedback on a set of recommendations that the Global Commission is due to release in the report due in February 2019. Let me introduce you to our presenters today. We have Jan Lecam, who you all know, Chief Executive Officer of Eurordis and Council Member of Rare Diseases International. He is also co-chair of the Global Commission Expert Panel. And he will present an overview of the Global Commission itself. And then he will be followed by Simone Boselli, who's Public Affairs Director at Eurordis, and who's very involved in the drafting of the policy recommendations of the Global Commission, and will be walking us through each one of the 3 tracks of the draft recommendations that you have received already. I have to tell you that there are 2 other people listening in today, and they will be collecting your feedback at the end. Tund Dignef, who's Public Affairs at Shire, and Christy Zettler from Rabin Martin, which is a global health consultancy firm helping the Global Commission put together the report. Jan, you can start now. I'm handing over to you.
Thank you, Paloma, and welcome to everyone in this webinar. I'm very pleased because that's an important step. It's the moment where we can share what this Global Commission is about and where the state of progress is, and to present to you the draft policy recommendation and have your feedback. So it's an important moment for us. So I will do this introduction to brief you on what is the Global Commission to End the Diagnostic Odyssey for children with rare diseases. If anyone has difficulties to understand or to hear me, please send a message. So the goal is what you know better than anyone, is that the time has come. We have a sense of urgency that we can shorten the journey of patients and those of their families to have a diagnosis for rare diseases. Because it's a moment where there is new knowledge, new science in genetics, new technologies linked to the genetics, but also new technologies in the digital, and there is also a new economic scale with the reduction of cost of using this technology, which then enables to identify and take advantage of new opportunities to address these challenges. So starting point, that's more for global communication, that you're obviously familiar, the number of diseases, the genetic origin, the time to get diagnosed when we have studies. So it's obviously worst in most parts of the world, but this is for the countries where we do have studies like North America or Europe or Japan. For instance, 40% of patients are misdiagnosed at some point at the beginning of their journey, and 30% of children with rare diseases die before the age of 5. So if we combine that time for diagnosis and the fact that we're dying before the age of 5 is a high burden for this misdiagnosed or for this diagnostic odyssey. So what are the barriers to diagnosis identified by the Global Commission? And after I will present you the Global Commission and the timeline of work. In our research, we found that first, there is new interventions that are needed, new possible actions needed to help physicians identify patients with a rare disease. The primary care physicians are on the front line. And as you will see after that, in terms of work stream, track of work, and policy recommendations, primary care physicians is a key element. We could say primary care physicians, but also primary care providers, because it could also be others than physicians in the healthcare provision. The and all the awareness of the physician about the existence of rare disease and the knowledge, the basic knowledge about rare disease across rare diseases, and where to find more information or where to find more medical education is needed. The second challenge we identified is that we need more geneticists, as we all know, but maybe we don't need to wait that many more geneticists are being formed and other specialists are being trained. Maybe there is other ways to develop the access to this genetic expertise, and it can be mitigated by using some of the new technology and new organizational aspects. The third barrier is the opportunity to apply new technology in the field of rare diseases, and that's clinical technology on diagnostic, and particularly from the area of genetics. But it's also how this advancement in science and technology are being transformed into useful innovations that can be applied at a larger scale to help the patients find their diagnosis. And the fourth is to streamline the processes. We have complicated healthcare system, so how can we streamline processes for patients to navigate their healthcare from the local or initial healthcare provider to get to the right specialist or and progressively the right expert and centers. And the whole issue also of referral processes and insurance coverage limitations. Obviously, in the context of the report, we will not be to address all these challenges, but to focus on some of them, which are more particular to the question of diagnosis. So the path to shorten the journeys to diagnostic, we thought that putting together a global commission was an interesting approach that was initiated by conversation that were going in a bilateral way between Jordis and the CEO of Shire and his colleagues, who were ready to engage into a big initiative to take corporate social responsibility of their leadership in the field of rare diseases. And also there was discussions at different levels between us and Microsoft, from pilots done with Microsoft in Spain and in Europe, and also at the government affairs level. And there was direct dialogue between Shire and Microsoft. So all that has converged very nicely. And then the initiative of Microsoft and Shire was to invite Jordis to join forces and establish a commission with experts, independent, recognized for their competences, and knowledgeable about the issue, and accepting to engage into a creative exercise. What we found as Rare Disease International, an interesting initiative, you have to keep in mind that when we started the Global Commission, that was at the end of 2017, so discussions 2017, really shaping at the end of 2017, starting beginning 2018. So RDI was not yet fully established as an independent entity. So it's progressively that RDI has been positioned within the Global Commission, as you will see, through different members, and that somehow we've shared and hand over a lot from Jordis to Rare Disease International. It's also interesting in terms of methods. I'm mentioning that for members, that it's not usually a global commission, or commission, usually national or international, are always associated with public authorities. So that's the first time we engage into a commission of experts, different stakeholders, but mostly academic and patients organizations, supported by private actors, and to see how that's working. So we're learning by doing that, and it has shown to be a very productive process so far. So very promising for next year for the launch, but after that for its impact. So the goal of that commission, with that in mind, is to develop a roadmap to guide rare disease field in addressing the barriers that I just mentioned in the previous slide, and to mobilize diverse entities to collaborate and to focusing on the diagnostic of children. All that work for RDI is positioned between within the United Nations Sustainable Development Goals number 3, so SDG 3, which is ensure healthy lives and promote well-being for all at all ages, and in the broader framework of the SDGs for the UN, which is to leave no one behind, which obviously apply to this topic of rare disease and in particular of diagnostic of rare disease. So that's how it fits with us. And a last comment on that is that, as we have had recently a webinar on the collaborative framework between RDI and WHO, World Health Organization, that's part of our goals too, to work on diagnostic with WHO. So we will bring some of the knowledge and recommendations of the Global Commission within the work of WHO. So I'm stopping with this long development on that slide. So the Commission overview, as a result of what I just said, is led by 3 persons: Fleming Onskov, who is the Chief Executive Officer of Shire, Simon Koss, who is the Chief Medical Officer of Microsoft and Director of Microsoft Worldwide Health, so the health activities of Microsoft, and myself in capacity of your orders and progressively identified as also Rare Disease International Council. The what is what I just mentioned, the roadmap, and a roadmap that focuses on solutions to address the barriers in children and for all rare diseases. All meaning, I remind for the one who had doubts, that is all rare disease, including rare cancers. The report will be inclusive, as you have seen in documents received before, but in the next slides, includes technical recommendations to address these barriers, pilots to implement concrete activities that have an impact and could be potentially expanded as pilots and scaled up more internationally, and policy recommendations. The report will be launched in February 20, 2018. So 2019, it's, oh, sorry, what I'm saying? No, it was announced, sorry, in February 2018, but the report will be launched 20 February 2019. So I was confused by the 20 February in both cases. And it will be, we'll see that in a moment, but will be, so time is running, but it will be launched from New York, and I will explain how. So that's the group of the council. So what you see here are the 3 co-leads, but you see the different medical experts, genetic experts, and patients representatives. So among patient representative, context of RDI, you have Pamela Gavin from Nord. So it's not Lisa, as Lisa Fels, as usual from Nord, it's Pamela here. We have Kevin Huang, who is the president of the Chinese Organization for Rare Diseases and its founder also. We have Mike Porat from Mighty, which has somehow a double hat into that, but is not a member of Rare Disease International, but provides a large platform for patients and was himself initially concerned in his family. And obviously we have our president of RDI, Durain Wong-Rieger, representing the Canadian organization. And Marshall Summer, by the way, who represents here Children National, is also a scientific advisor to Nord. So we have a good group. There is the people you don't see on these slides, which are doing most of the work, if I may, which are what we called, in a very politically correct wording, the expanded team. And that's the expanded team of Shire, where there is great colleagues extremely dedicated to it, and particularly Lynn Paresh. At Microsoft, there is a dedicated team also with few people, and in your orders and Rare Disease International, the colleagues that you're hearing today in this webinar. So the barrier to diagnostic for each track, they have been divided in 3 tracks. The first are the barriers for patient and family empowerment. So as a patient and family, when there is something wrong during the pregnancy or something wrong at the birth of the baby or with your child, we know it starts like that, right? There is something wrong, we know. Now, what do we do with that? And how we navigate then? Where do we find the doctor? Where do we find someone who knows? So this difficulty of navigating an often complex healthcare system and fragmented, fragmented because of the coverage, fragmented because of the geographic distance, but also because our diseases are so rare and so much undiagnosed, so many people not diagnosed, so small numbers, then there is also that fragmentation, the lack of expertise about all the diseases. Not alerting the physician and on the symptoms, the fact that when we approach a specialist, he will look only at the symptoms we're describing in the field of his or her specialty. They will rarely look at us in a holistic approach with our different symptoms and our different aspects or different disabilities or dysfunctions. And also the lack of the medical credibility. We know from experience, right, that it is a barrier. We describe what's wrong, and then doctor says most of the time, not always, but most of the time, no, or are you sure? So we're not credible about what we're telling, and the lack also of patient-centered information. So it's difficult to find that information in most countries around the world. The second are the barriers to the first-line providers. So there is a lack of training, as I mentioned previously, in the barriers of the physicians, but also of the other healthcare providers. Some of the nurses, even specialists like the pediatricians and etc. So this lack of initial and also of continuing education. The lack of standard criteria to help diagnose many rare diseases. So you have to know these diseases to go through your criteria, but there is no standard tools on how, from the symptoms I have, does that take me to a diagnosis, right? So there is not that kind of intelligence. The intelligence is based on the experience of a certain physician in an expert center. There is poor communications between the primary healthcare physicians or providers and the specialist, a lack of awareness, and a lack of access to diagnostic tools, particularly the most innovative ones. And just to mention the genome, the exome sequencing and genome sequencing ones. The third are the barriers for genetic consultation. So when we have access to that, okay, what's next in terms? So there is a shortage of geneticists to interpret the growing capacities of sequencing and genetic and other sorts of genetic analysis, and that's an issue because there is more genes identified, there is more technology to analyze the exome and the genomes, there is more information, but it needs to be interpreted. So that's a big bottleneck. So how we overcome that shortage, and that brings a burden on the healthcare system with an inability to see more patients, waiting list, and just trying to escape the system because the system doesn't work. And there is the geographic issue. So already the spreading of expertise in regions like USA, Canada, part of Europe, Western Europe, or Japan, or Australia. So in some countries like that, already the geographic distance is a problem. You can imagine that countries like Finland or Norway have similar challenges like Canada or Austria. But it's even true for countries like Japan, where there is a high concentration in urban areas. So this issue of population is key, and maybe we need to think of strategy not only in terms of countries, but in terms of density of population, so also in terms of cities to address these issues, and we need to think about the people in the rural areas. And there is also issues of inefficient practice that limit the productivity, the lack of follow-up visit, the fact that there is a lack of all the delivery chain, I would say, of the diagnostic is not well in place. So for this, to address some of these barriers, not only we've developed technical recommendations that you've seen in draft report, but also pilots. I'm a big believer into these pilots, and I have great hope that some technologies can be developed today to make a frog leap, really, a big jump in addressing some of these barriers. So trying to really make a significant move. So I'm not go into details to describe them because you receive the document in advance, but that can go from telemedicines for remote consultation between doctors or between by specialty or between geneticists. It can also be face recognition for phenotypes. It can be also to aggregate phenotypes entered directly by patients together with a genotype. It can be conversations between patients and caregivers to collect relevant information that can be used by specialists. There is also the new technology of the blockchain, which can be a real paradigm change for us in terms of custodianship of our own data, not in terms of ownership, but having the responsibility of who we share this data with and having them all along our life with us and be able to share it at the needed time point. So there is these different pilots that could help to make a significant difference because we'll be able then to evaluate their impact before scaling up. So the timeline, we are now in October with the 15 October, 1st November to have inputs from the Commission members on the report. And we have in the middle of that, the consultation now with you within the Rare Disease International. And then all that would be consolidated and sent to have a final draft by the beginning or mid-December. And after that, we have the publication in January and the launch in February. Sorry, maybe I go to that first. The launch in February would be from New York at the headquarters of Microsoft. So in itself, it's conveying a message. And because New York is a bit of a mirror of the world, right? It's a small scale of the world, but at the same time, it's Microsoft headquarters. And we will organize that day, the Rare Disease International RDI membership meeting, where you are all invited to attend. And the same day, we will all attend the launch of this report from the Global Commission. And the day after, we're going to the UN, as indicated on the slide, to have the second event at the headquarters of the United Nations on rare diseases. And that will be the policy event of Rare Disease Day. So very powerful moment. And at this end, the launch in New York will be simultaneous in Brussels in partnership with Friends of Europe, which is a think tank on European policy. And a few days later, so 7 days later, on the 28th, on the day of Rare Disease Day, there will be the launch of the report in Beijing with the Chinese Organization for Rare Diseases. So Rare Disease International is involved in this Global Commission, not only through myself, but as I mentioned, through Durin Wong as president of RDI, Kevin Wong, and you know that Rachel, representing Chinese Organization for Rare Disease, is now on the Council of RDI, and Pamela Gavin from Node. We have now this webinar to provide high-level inputs on the recommendations. And after that, you're all attended to attend this Global Commission launch event on the 20th of February, when we will have the RDI annual meeting. Obviously, it can also provide media opportunities during these 2 days. And also when you go back home, obviously you can create your own media opportunity to disseminate these key messages. So the event at the United Nations is on the 21st. It's all day. So if you're starting to look at your flights, rather try to plan to go back the day after or late in the evening, not to miss the best parts of that. And as I mentioned, it's a Rare Disease Day policy event, and it's hosted by Estonia, but also now by France and Belgium, if I'm correct. Okay, whatever. So progressively, we're extending the list of member states, and next week we have series of meetings in New York. So this list will get longer. So I think we are very much on good track for an important event that day also. So now I stop and I hand over to Simone Boselli, who is the Director of Public Affairs, so International and European Advocacy, and member of the RDI Advocacy Committee and the so-called extended team in the Global Commission.
Thank you, Jan. I'm very pleased to be with you all today. Before I begin, I wondered if there is any really burning question for Jan for what he has presented. Otherwise, I will start talking about specifically about the recommendations that have been put forward according to the 3 tracks, as well as the policy recommendation. It doesn't seem that we have any questions. Lucy? No. Okay, that's very good. So what I'm going to tell you today, and in the next 10-15 minutes at the maximum, is what we have looked at into terms of providing recommendation, building up on what Jan already said in terms of the identification of the barriers for patient and family empowerment, first-line provider engagement, and regarding the how to reimagine the genetic consultation. As Jan mentioned, the policy recommendations sit across the 3 different tracks, and they are positively linked with the pilot projects in technological innovations that Jan briefly explained, which are quite innovative, and we hope that really will speed up the progress on diagnosis across the world. If we go specifically already then inside the different tracks, we have 2 different levels of recommendation. One are a very technical recommendation, and there is another layer of policy recommendation that are considered as enabler of the specific recommendation. The first one that is the first 2 that could help in having a better and more empowered patient and family relatives of people with rare diseases are how do we empower the patient to be bold enough and certain enough to ask the doctor to think differently, and particularly to seek that all the families are empowered and have the real tools that they need to ask the right question and get an answer specifically, as Jan highlighted in the challenges in particular. And secondly, blockchain might be one of the buzzwords that is on everybody's mind at the moment, but what it really is a technology that will allow the patient to and their caregivers to be able to have the medical records at disposal with different multiple physicians. As you know, the challenge is that different data are hosted by different medical providers or professionals, and most of the time those different data sets do not talk to each other, and we have a lot of problems in carrying them around. Using the blockchain technology, the system would allow the patient data to be aggregated and be available for physician and parents included. So that's parents can also manage the data in a patient-owned system, and maintaining the control of this data and empowering them to have their personal passport. In the second track, in terms of solution, again, AI or artificial intelligence is increasingly being looked at as an enabler to both identify rare diseases, but also further down the line to identify what potentially the treatment might be available to be identified for development. But specifically with the identification of the rare diseases and in relation with the diagnosis, artificial intelligence can help learning from medical literature based on identified symptoms for each rare disease. So if all of these terms are aggregated and put into a simpler interface for the physicians, the physician might be also helped to find a diagnosis or identify a way to find a diagnosis much quicker and more accurate over time. Secondly, and related to this, is to facilitate and expand access to diagnostic testing with a vision to provide greater access to what is available for diagnostic testing for patients who would be benefit the most. Ideally, this platform would allow first-line providers to provide patient information to panel of experts online. This has been, to some extent, experimented already in Europe through the European reference networks and the virtual consultation that is currently ongoing. Hopefully, the results will be faster and more accurate diagnosis, and the relative potential savings to the healthcare system might be achieved, thus maintaining a sustainable approach to health system, because we all know how difficult it is to navigate the systems and the related again odyssey that we have to go through to find an accurate diagnosis. In the third solution, in terms of how do we reimagine the genetic consultation, is to establish early access centers in genetic clinics, by triaging or having a first selection of the information that arrive to understand a child's current health needs, and determining whether a general consultation is needed and which additional tests should be conducted beforehand. It's all about, again, like in the previous recommendation, about collaboration to allow for a more effective and efficient visit with a genetist, again, saving valuable time for both the patients, the family, and the healthcare professional. Finally, as the last specific recommendation for these free tracks, is to allow information capturing and a remote consultation for rural patients, in order to ensure that everyone, even in remote areas, have access to the same type and the same quality of diagnosis and care that they deserve. So practically, that will allow, through an online form filled in advance of a genetic consultation, to share the form with especially before the appointment, to ensure a productive session, and then avoiding a need to multiple in-person appointments, but also followed by virtual consultation in order to avoid unnecessary travel and time. And this is entirely possible with the ICT, with the technologies that are currently available to us. As I started to in the introduction, originally the policy recommendations should have sit as a separate track, but in the course of the discussion, it makes much more sense to integrate those policy recommendations as part of the free tracks that I have highlighted beforehand, in order to provide the fundamental blocks from a legislative point of view, to ensure that the solution that we're providing with the Commission might be able to be deployed. The policy recommendation again supports the solution tracks, and so far we have very specific recommendation already developed, and you have seen in the pre-reading, but specifically on center of excellences, on genetic screenings, on legislation and data sharing, but at the same time to encourage the respect of privacy when allowed. In the specific tracks, we call for the appropriate level of government in track 1 to support platform for shared actions. Again, like very much what is potentially happening in Europe and slowly taking up sharing electronic medical records to improve diagnosis efficiency and recognize the benefits, as we see again in Europe, of cross-country rare disease research networks on best practice sharing. For track 2, it will be important to put in place standardized protocols for diagnosis and referral between primary care centers and center of excellence in order to have a faster diagnosis in place. As the second part of this, in the third, for the third track, it will be important to recognize where center of excellence lie, particularly outside of more advanced countries, and building up on what is already existing, establishing regional center of excellences and or networks to speed up the diagnosis, recognize better standardization of clinical practice and coordination between countries, where center of excellences are not existing or the standards are not sufficiently high. Governments and healthcare authorities should step in to issue clear plans to develop center of expertise for rare diseases. Interoperability again is essential, that when COE's network, center of excellence networks are established to optimize data sharing, and then support investments in data network and connectivity to ensure uniform adoption of the technologies. On genetic screenings, with much more detail as well and more specific, the development and implementation of genome sequencing strategies should be addressed in order to have strategies that screen patients with a sufficiently broad and targeted gene panel to support diagnosis of rare diseases where there are known interventions. Then when we talk about access, pathways should be ensured that should be put in place to ensure that the access to the diagnostic tools is available. The infrastructure that supports the development and implementation of genetic sequencing strategies is to be financially supported, and training should be incentivized for primary care in order to have early adoptions of novel approaches. On data sharing, again, the importance of having governmental support and as well as financial support for shared action across stakeholders, whilst at the same time ensuring that there are privacy guidelines for the use of health data in order that the sharing of them is encouraged and secure, and then the cross-sharing of electronic medical records is enabled to improve efficiency of diagnosis. Interoperability again is one of the important recommendation here to ensure that data sharing is optimized This is not self-evident. Even in Europe, although interoperability of health records has been on the political agenda for the past 15 years, that hasn't been sufficiently adopted. And then supporting investment in data network and connectivity to ensure an uniform adoption of technologies. And this sits well with an overall global, I would say, drive to support investment in ICT. And whilst we all, patients with rare diseases and people with rare diseases, recognize the need of sharing our data to improve research, we need to have privacy guideline in place to ensure that the consent is there and we understand what the use of our data is done for, and that we can have, for example, tools like artificial intelligence seek through a greater deal of data, and the sharing of electronic medical records is done whilst preserving the privacy for those records and for those patients. Areas where we would like your feedback again, we have some ideas in this area, but if you have any recommendation for us in the area of empowerment of physicians or tools that will strengthen the cooperation of the community of rare diseases, this will be very much welcome. And with this, that is pretty much it from my side. Yes, indeed. That's all. I hope I haven't bored you with too many details. This has been quite an intensive work to make sure that the different tracks are aligned with the recommendation and the pilot project in order to have a complete package. Thank you very much for your attention, and please do raise your hands if you have any question for myself or for Jan, and if you have any suggestion, we will be open. Even if not today, you can send us in writing your comments and recommendation.
Thank you, Simone. Thank you very much. So please, we listening for questions, so you can raise your hand on the webinar and you can speak either by microphone or you can type your questions as you wish. I know it's not always easy for Paloma.
Yes, I'm waiting for someone to ask a question. Okay. You can write a chat.
For you to understand what I said, that is because you appeared on the screen suddenly as Paloma Terrada, so I thought that you had.
If I may, if it is not, you know, perhaps not for today, but if any of the participants would like to tell us what is your take on the Global Commission, if this recommendation would be helpful for your local work, that would be very, very helpful for us. It doesn't have to be necessarily also for today. You can also follow up with myself at a later stage, and I can put forward more.
What's the deadline that was put into the email, Simone, for everyone to send comments so that we can consolidate?
I think we have whilst we're doing this with the RDI members, we are also asking the experts from the Global Commission to provide input, I think, by the 5th of November, or certainly the week of the 5th of November.
Okay. We have a question from Ritu Jain. So Ritu says, there has been a lot of information, and I'm not sure if I missed it in the beginning of the presentation, but is there a consideration of cost as a primary barrier to diagnostic? So what is the approach on cost in the report, Simone?
On cost, on access to diagnosis, I think there is, if I understand correctly, there is a recognition that there are sometimes economic barriers to diagnosis, and that's what we are seeking to address, but via potentially having virtual consultation and linking up different countries where there are not enough representation of geneticists or adequate diagnosis to link up with other countries where there is a similar language or a similar knowledge, so that the cost could be reduced. It is true that we did not address specifically the issues of cost everywhere. It would have been quite a long job to do. This is true that when it comes to diagnosis, particularly from genetic side, we are seeing very much that there is a decrease in the price because there is innovation in it, and there is better availability.
So there is another question that we're going to go through on data, but staying on the cost, maybe what I suggest, we'll see if there are other comment that direction. Oh yes, Ritu is adding. By the way, hello Ritu. I know it's not easy, this webinar. We are most used to the Zoom process, right? It's more lively. But in my experience in Asia, Ritu says, this is the most significant barrier to diagnostic, of course. The lack of facilities is just as significant. So I wonder, I'm talking to Simone, but also to the colleagues online, supporting us in the work of the Commission, is that maybe in the barrier, we should identify more clearly that cost is one of the issue, cost for the healthcare system and potentially cost for the patient and families when there is an issue of coverage, and that in the technical recommendations and policy recommendation, we can find some of the answers, particularly on what you just said, Simone, the fact that some of the solutions provided in the report around new technologies are bringing down some of the existing costs of these current technologies, particularly in genomics, or also different tools, how they can trigger economy of scale. Now, that is already when you have an access to genetic testing, because the first barrier can be that you don't have access because simply it's too high. So even if the cost goes down, you can still not afford it because your system is not covering. So I would not suggest to get into the figures or into any details, but maybe we can identify that more visibly as a barrier in some countries, and with a double aspect of the burden on the healthcare, but also for the families, and on the other hand, or we're trying to address that. So for I'm going back to our colleagues from India, but then Kelly Duplessis from South Africa says, in Africa, simply accessing data is a problem for patients in rural areas. I am unsure how we could overcome that barrier, but I do believe we need to harness technology to break through the barriers. And that is in correspondence to our colleague from the Organization of Rare Disease in India, Shimbavi. Hello, Shimbavi. And she says, the policy recommendations looks great. I have a question on the data collected. Data is key to the whole plan. Do you have guidelines on the standardization of the format in which data is collected, stored, and represented in the online portal? We would need such standardization so that the data can be shared internationally across governments, so that the data can be understood, right? So that goes together with the comment from Kelly, and I say hello to Kelly at the same time. So Simone, how are we, because the standard templates that take us to other groups, right? That EARDIAC has developed standards on that, for instance.
To some extent, yes, but also we need to also standardize designation of orphan diseases. For instance, we would provide examples also on the type of the common data sets that are being collected, for example, in Europe through the European Reference Network. I think this is an idea. I don't think we will go in as far as providing guidelines on how these if I'm looking again at the question of how the data is collected, stored, represented in the online portal, but that's something that we could bring together. I think it would be great if you can standardize across the world from day one, but I think it might take a little bit longer. In this sense, there is one.
But maybe what we could do is a link on these aspects of data. I don't think that we have made that kind of link to existing references that we can use. And the simplest I see for now, but there might be others that we could think of going back to some of the background work of Charles River, but would be to liaise to IRDIRC, the International Consortium on Research on Rare Diseases, because that brings already official representative from the research funding agencies from around the world, starting with NIH in the US, Canada, several countries in Latin America, China, Japan, several countries in Europe and EU also, etc. So there is Turkey, so different countries around the world. So that, and here there is some standards on how to share data, on harmonization, on minimum data elements, and also interoperability. So there is elements like that maybe we could refer to. So maybe we could at least do that. On Maria Schneider says to us, hello Maria, that the Commission is focusing on the earlier stages of diagnostic journey, even identifying the need for a diagnostic test. Is that, am I missing? Yes, it's true. It's on the earlier stages. Now, it doesn't exclude, but maybe it's implicit and could be more explicit that it's also the diagnostic that a patient can have at different moments of their lives, because often we have several diseases associated. It's a syndrome of several pathologies, or it's a comorbidity of diseases appearing over time in our rare diseases. So the diagnostic issue is usually not just a one shot at the beginning of but the most important one is to identify which rare disease it is, the initial one. So yes, we're focusing on this initial diagnosis that gives the medical entity identity, but maybe you're right, maybe we should insist that there is other stages of diagnostic. So maybe it's a comment to take on board, Simone and Toon and colleagues.
That is a good comment to bring in. I'm responding to Ida's question now on how we will bridge the diagnosis to care, what is treatment, or whatever will be needed. That's a complex questions, in the sense that the Commission is looking mostly on diagnosis rather than treatment or care. However, that's why we are looking at center of excellences as well, and recommending the establishment of that, because really what is the point that you're making is that once the diagnosis is done, and we hope to have better quicker diagnosis, then we need to link to where there is either a treatment available or anyway care, and we realize that the same level of care or treatment is not available all around the world, and that's why we need, and sorry to say that perhaps just replicating or at least taking the inspiration from the European Reference Network, that we need to put in place center of excellences in each country, but also put them in a network to ensure that there is a follow-up to the diagnosis.
So Eda, it's Eda Celebasto. Thank you for this comment on bridging diagnostic to care, and I fully agree. I think we all fully agree with your question. It's true that this Global Commission report is focusing on diagnostic, and as Simone says, the issue of diagnostic is the fact that nobody cares for you and you don't have at all access to diagnostic because nobody recognized there was something wrong for that child. Then it's the absence of treatment is not the motivation. The fact that a treatment exists but is not available in your country is also demotivating access to diagnosis. The uncoverage, so there is different barriers and element, and the absence also of a center of expertise where to go, or an expert where to go. But here we try to stay focused so that after that we could move on to the other aspects. So for the just to give you a sense of that, for the event at the UN in the program of the 21st of February, would precisely go from that, from awareness to acceptance of the disease also, and then diagnostic, and from diagnostic to healthcare organization. So to provide this transition and understanding in a more high level approach. So we're not solving that completely. I'm going back to your previous question, Eda, that says that these are great recommendations, but I need to get how this will directly reach our government, especially in Africa, not from one voice, but as global community of rare diseases. Thank you for that question, because that gives me the opportunity, in fact, to say that obviously there is the impact that we can have with a launch in New York and in Brussels, as I said, and in Beijing. After that, there will be presentations in different conferences. Every time it's opportune, let's say during 1 year or 2 years, to try to disseminate more. But there is a key element which is part of the plan, is the appropriation of these recommendations by the members of RDI and to advocate from it, but also by the scientific community. And last, and I stop here, it's also the work we are doing within the UN and within WHO, so that we hope that down the road, progressively, elements of these recommendations will become recommendations within the WHO. So it's not an immediate impact, but if we could get that as recommendation, then locally in Africa, potentially, from what I understand of colleagues working in different regions of the world, then they can use the fact that there is a recommendation made by the scientific committee first, the Global Commission, then after saying there is a recommendation made by WHO, and then to use it locally. I'm going now to the question by Cornelius Mulvan. So, hi Cornelius, Mulvane, sorry, from Rare Disease Malta. And he says, thank you first for the presentation and emphasis on primary care, particularly the role of the general practitioners. I understand that this sector needs further training, especially also to help families to be able to communicate better with them. And how does the Commission help to see that further training is given? So Simone, the recommendation on training of physicians, what do we have really in the report?
On the recommendation on training specifically, we include funding for training, resources for training, but at the same time, one of the main recommendations that we have that is how to help them with IT technology, particularly with the machine learning pilot projects, for instance, that will look at recognizing faster what the different type of symptoms are related to a disease. This is one of the pilot projects specifically that our colleague Julian Hisla from the Dravet Foundation and Microsoft as well is looking at to help primary care physicians to have tools at their disposal to look at what symptoms might be and having a faster or better understanding of who they should refer to. And that is really very much the application of artificial intelligence and machine learning to rare diseases. This said, I think that what is very important in their recommendation is trying to make sure that physicians do listen to patients and their families once they come with a problem that is not resolved, and that there is an opening to understanding and an opening to listening from physicians.
I guess what we're saying in the report is to say that it's not an objective to try to train the GPs for sure, but even the specialists in rare diseases. The first thing we need to do is to raise their awareness in general so that they know that these rare diseases exist, and that when they have doubts about the situation of that child, of that neonate, of that grown-up child, then they practice the doubt of what if would be a rare disease, and then use new tools that we could provide to this with these pilots, as Simone just said, using artificial intelligence, and then taking them to validated resources, because all the pilots on artificial intelligence working from the symptoms and matching that with the genetic analysis when available, but at least working from the symptoms already, take you to different potential diagnostic, but using standardized tools like the human phenotype ontology, using the Monarch database, using the OrphaNet database, so using tools which are high level, high quality, and highly validated. So this is how we see the trainings, but at least as it is mentioned in the report. Now, if we think further, obviously other forms of training would be great, particularly developing MOOCs and other forms of online trainings. But we have the barrier of language here that comes immediately. So it's a question we raised, in fact, to Microsoft as a potential challenge. But if we were able to have trainings developed in English and translated simultaneously in several languages, that would be stimulating for the to develop new type of training. So, but that we're not going as far as that in the report. We're more cautious. Atia from Malaysia, you mentioned your name, but thank you, which is nice. We're glad to know you're online. Do you have a specific questions that you would like?
I see it is that what Atia's question was around specific experience in Malaysia, that pediatrician believe that genetics are not important because the pediatrician are doing all the treatment. Well, that's true and not true, in a sense that perhaps it is true that the pediatrician are doing the treatment, but at the same time, as we see it, that there is a need for an approach to geneticists to have better and faster and a more accurate diagnosis. So perhaps there, and I don't know the specificity, maybe at here we can have a separate conversation on it, and please do send us what information do you have in Malaysia, so that perhaps there is an education to be made with the pediatrician to make sure that they are aware of what potentially is for pediatricians, geneticists.
I wonder, as we have the privilege to have members here online from different parts of the world, from Singapore, from Malaysia, from South Africa, and more. The way you see the report being presented on the role of the healthcare providers, and particularly the healthcare, the physicians, the GPs, do you have suggestions on if we should say differently with the healthcare providers? So how much we should go on the role of the other healthcare providers, which are the primary care providers on first line? I'm thinking pharmacists, I'm thinking nurses, I'm thinking dispensaries and other. So do you have any potential recommendations here to adjust? So we got the other clear messages: the cost, the lack of attention anyhow, which is the availability of the testing. So all everything you said we've already taken on board. But so if someone think about it and wants to have a quick scan of the document again and say, okay, how we should position because I'm afraid that our report is still very much based on how we see healthcare in the most high-income country or most healthcare advanced countries, but maybe not enough adapted to the low-income or middle-income countries. Do we have?
Well, Jan, I suggest that if there is someone that wants to say it now, that's great. Otherwise, in the follow-up, we can you can write us an email, send us information that what's Ritu saying, the Asia Pacific region geneticists are almost off the radar. Pediatrician takes center stage. Yes, yeah, that I take it, and this is definitely
Yes.
something that we need to report.
Yes.
Ritu, your comments are
That,
important.
yeah.
Kelly, communication breakdown, and the under resources. Okay, okay, that's very much true.
But that's why, because I thank you for these two comments, Kelly and Ritu, because I think that's something we need and can take on board, because the pediatrician, we know, right? They are first line and they are key. And here, it's not only about working with. I'm looking at it, sorry, from the international perspective, but looking at it on WHO, but also it's UNICEF. UNICEF plays a key role, right, with the pediatricians and with the primary care provision for pregnant women and for young mothers and children. So here we have also potentially the line of action in recommendations and in the work of RDI and the NGO committee. I'm sorry, I'm trying to see at the same time there is, okay, I think nurses, so Shamvavi is saying that I think nurses for sure needs to be a target of the training, because rare disease patients often require multiple visits to test for procedures such as tube change and etc. Exactly, they need to understand the special circumstances. Kelly is adding, we also have only 12 geneticists for a population of 60 million people. Yes, good luck, that's right. Genetic services are only available 3 to 9 of our provinces. The rest of Africa is worse than us, obviously, and Kenya didn't have one geneticist. And thank you, Matija, for sending the situation in Malaysia in a separate email. That's great. So here too, because we're using the digital tool here, that can be a big changer, because using your mobile phone, a nurse can then have access to information. If we imagine tomorrow a nurse entering symptoms that she sees in a baby or a child, and she says, okay, this child has not been diagnosed properly, so I'm going to do it myself. So entering the symptoms, and then through this artificial intelligence, then finding the right terminology with the human phenotype ontology, and then being driven to one or several potential diagnoses, that helps a lot, because then suddenly you're entering into a sphere of knowledge, just instead of just being confronted with difficulties and you're not helped. So suddenly you can be helped, and you can be helped through your laptop or through your mobile phone. So that's typically the kind of jump we're trying to do. So Cornelius is saying, in relation to Jan's recent comment on the others members within primary care other than GPs, I recommend that these other members, nurses, chemists, social workers, etc., be trained, especially because of families are very near to these people, and at times such people may act as communicators with GPs in comfort to family. Yes, Cornelius, I think we all agree that takes us to the holistic approach and integrated medical social care. Absolutely, and that starts, we agree, with awareness first and then education. So in terms of diagnosis, maybe what we can reinforce as a message, so I'm saying that more for the colleagues from Rabin Martin with us, is maybe to say that the raising of awareness and about rarity, about when something is wrong, that it could be a rare disease, so this culture of doubts and orientation should be targeted not only to physicians, but to the other healthcare providers and social workers, or even teachers at school. And so Kelly Duplessis is saying, we have had a very successful, I guess it's a meeting of geneticists, right, program, whereby we train community carers and workers on identifying congenital defects to ensure that they get referred up to primary hospitals. The program was usually successful. So medical genetics education program, thank you. So it's not completely far, medical genetic education program. So I believe that focusing on educating healthcare workers is very beneficial. That's a great recommendation, because we're building on something that exists and we know it works. So if we could integrate that in our recommendation, I think that that's really good. Training community carers and workers on identifying congenital and other congenital defects and other rare disease. That sounds great. So Shambhavi is adding, there is one other issue, the difference in services provided, diagnostic or otherwise, between private hospitals and government hospitals. So in India, I think the experience has shown a reliance and even a dependence on private hospitals, where costs are invariably higher, obviously, and I'm hoping technology, telemedicine, and artificial intelligence can reduce that gap between the public hospital and the private hospitals. We would need to have some kind of training for government hospital in addition to the usage of artificial intelligence. Thank you for these comments. I think they are very, very useful. Thank you to all participants for getting into this dialogue through the typed messages. That's great, because they're also recorded so they can be revisited by the colleagues when consolidating the report. We're getting close, maybe to closer to the end of this meeting, so I would like to call for additional comments that you may have on any parts of the reports. So I don't want to call each of you by your name, but I have a question, in fact, to all of you, if you want to take that one, is that you've seen the pilots in documents we send you and what Simone presented. From what you can understand, because I know that it's words, so what you can understand from these pilots, which ones you think are promising, can be very useful, can create a positive change in your country? If you are able to answer, because I recognize it might not be so easy only by reading the pilots without a live presentation. So Ritu, yes, you asked me to repeat. Yes, that's what I was guessing. From the pilots presented in the report we sent you, and also what Simone presented briefly, there is different pilots. So I'm asking you which ones you think can create more positive change in your country. So in terms of which one seems the most useful, but also the most feasible. So there is, for instance, the pilots on the artificial intelligence that enables any healthcare provider or any parents to enter the symptoms and then be driven progressively through questions into potential diagnosis, which then you can go to the right specialist or go to the right hospital and try to discuss the situation of your child, and then maybe have a gene testing to confirm or not. There is also the pilot on direct dialogue between experts, between geneticists, which exist already in some other disease areas and could be expanded to the field of rare diseases. So having the few geneticists around Africa communicating more directly together in this platform, but also communicating with geneticists in other countries. So that could be a way to leverage the capacities, very limited capacities, as Kelly said. But so that kind of things. So Ritu says, will be helpful if we can have more slides to in another email. Yeah, yeah. So quite depressing comment, but fully understand, Ritu, you said that at this point it seems almost impossible in your regions. Okay, with infrastructure that doesn't exist here, so we sound quite remote then. What Atija from Malaysia says is that empowerment of family members so that they are able to help physicians. So anything that reinforces the autonomy of the parents to help find a way for diagnosis is good. So I think that's something we can take report. EDA says that artificial intelligence used to assist in diagnosis by sharing and also sharing data. have patients struggling to get diagnosis. Yes, yes. Data security is a huge topic in Germany. That's Christine Mum saying in Germany. So I don't know how this will work out in the future of data sharing. Yes, I know. And there is the new European data protection regulation implementation ongoing. Okay, so I think as a next step, so I'm speaking to the extended team. Maybe as a next step, I think if we can reuse some of the slides that we have used in the Global Commission, meeting in Seattle, if we could share that, maybe not on all pilots, but on the strongest pilots, we could share that with the participants of the webinar today by email, going through Paloma, then we could maybe get more feedback about that, because I'm a bit concerned that there is a perception that maybe these pilots are difficult to implement in the country. So maybe they need to see how that can work. Because if I take to Singapore, patients, your families all have a laptop or a mobile phone. So the kind of tools that we're thinking are using that precisely to try to go around the obstacle of the lack of infrastructures. So it's not solving all, but it could solve or help many people. So what I get from that discussion overall of today is that maybe we're not conveying enough the message of how this recommendation and pilots can have an impact in a lot of places in the world where there are these at least a minimum digital equipment. So Shambhari is saying, I'm quite intrigued by the passport ID. I think that would be something we could at least, yes, test with Raspberry. Absolutely, that's what we think with the blockchain. It could go with some sort of a passport that we carry with us constantly, and we can go to emergency room or when we're traveling in another region or another country. Cornelius, anything that has the potential to bring further awareness among doctors and specialists, followed by training while supporting families in their field. So thank you. That's a very clear sentence that can help to focus some elements in the report. Thank you. So anything that has potential to bring awareness among doctors and specialists and maybe other healthcare providers, and the training and support while supporting the families with autonomy, as we had in previous comments. Great. Okay, yes. Thank you, Ritu, for precising. So you were saying the region, in South Asia region, not specifically Singapore. Yeah, that's why I was a bit surprised. Okay, I got you now. Yes, sure, because you were talking for the more broad, beyond Singapore for the other countries. Thank you for this comment from Germany. That sounds more familiar with some of the meetings that we have right internally with members in Europe, right? We have often with German friends say, okay, we feel like being on another planet. Okay. Yes, Ritu, your comment were for India, Indonesia, Pakistan, Philippines. Okay, superb. Okay, thank you very much. I'm giving you, if you want a last minute, if you want to send additional comment now, keep in mind that you can continue to send comments after and emails. So my thank you, Toon, for this comment. Yes, I agree. It was a slow start, but we get lots of great comments, which are going to help us to improve the report. I'm sure that colleagues also at Robin Martin in New York will be happy with that. Thank you. I really believe that this consultation, although we know how challenging it is technically for everyone and with the time difference, so thank you for making the effort to all of you. I think it has been very useful because it helps to see that there is elements that are going in right directions, but we need to refocus some elements according to priority level you indicated, but also the meaningfulness in more parts of the world. Thank you very much. Thank you for the nice comment, and I cannot thank enough some of you for very well thought comments and sentences which are going to be helpful. Thank you all. can I hand over to Lucy? Is it to you to close the meeting? Is that how it works?
Yes, sure. I would say thank you to everyone for joining us today. And as Jan said, we'll be sending a recording and all the slides as well.
Yes, so the recording, by the way, colleagues, and that will be sent to all members of RDI again. So if you have not attended, or if there is someone you know who has not attended and who wants to listen, and after that send comment, please do. As long as it is among membership of RDI, everything is welcome. Deadline is 5 November. Thank you very much. Have a nice day and a nice evening for the others, and a nice weekend for the one who are going on weekends. Thank you. Thank you, Toon. Thank you, Chris. And thank you to my colleagues also, Paloma, Simone, and Lucy. Thank you. Goodbye.